Hello, and thank you for joining us on this exciting Philips-sponsored SCCT webcast entitled Emerging Developments in Cardiac CT Imaging. I'm Christian Graziano, CT Clinical Marketing at Philips, and I will guide you through today's discussion surrounding some exciting developments in cardiac CT imaging. Our talk will be divided into two different sections. One of each will highlight different emerging disciplines that show incredible promise. First, we will invite Dr. Jodher Sandoval, interventional cardiologist from Minneapolis Heart Institute at Abbott Northwestern Hospital, to speak about CT-guided percutaneous coronary intervention. Dr. Sandoval will touch on some of the current challenges he and other clinicians face, as well as his experience using emerging technologies to address them. Next, we will shift over to Rolf Reimakers, one of our own clinical experts here at Philips. Rolf will provide his unique insight in terms of the direction of Philips CT, specifically regarding spectral CT in cardiac imaging, and how that is being leveraged to not only address current challenges, but surpass them. So with that, let's get started. Dr. Sandoval, I will hand it over to you.
So thank you again, Chris, for that kind introduction, and to Philips and SCCT for providing the platform to discuss this very timely topic of CT-guided PCI, which I'm sure many of you have heard, that I think has had a lot of traction and interest for a number of reasons that we'll discuss over the next 15, 20 minutes. But I think in large part it has been very refreshing to see our scientists, imagers, radiologists, and interventional cardiologists to come together to understand how to do the best job we can for our patients with coronary artery disease. So again, I'm an interventional cardiologist. I'm not a radiologist or imager, but we've really embraced, try to really maximize all the opportunities that CT brings to us as it's increasingly being used in patients that come to clinic or to the hospital with anginal symptoms, to try to leverage that information for pre-procedural planning. So with that, our goal is really to talk about this, how we're entering this new phase of using CT to guide PCI for coronary artery disease. So as you've learned, this is, again, thank you to SCCT for providing the platform for us to discuss about this. But a lot of this has taken a tremendous momentum, particularly, I would say, over the past year. But it's something that's been happening now for several years, largely because now I think it has really made a transition, and there's been really an inflection point from being something that maybe a few centers around the world were doing to now something that now both the Society of Cardiac Angiography and Interventions in North America, as well as the Society of Cardiac CT, really understood, really this is a very important opportunity for our field to help our patients with coronary artery disease, as I alluded before, and came together pretty much, last year in 2024, we all met together, groups of people that were interventional cardiologists, trialists, imagers, physiologists, radiologists, people from really different backgrounds came together and said, how can we define what exactly is CT-guided PCI, what are the unmet needs, and how can this be incorporated into clinical practice? I want to start by the definition, because this is a term that, it is quite possible that you have heard by now, in different venues. But many of us might potentially, you might still be scratching your head as to what exactly is CT-guided PCI. And I do want to make that distinction, right? We have been using CT for many, many, many years to diagnose coronary artery disease. And it is not infrequent that many patients come to the cardiac catheterization laboratory for an invasive coronary angiogram or for PCI with a prior CT that was performed as part of the clinical evaluation. So we're not talking about a CT that by coincidence was done prior to an invasive procedure. The key word here, the key term here is that this is interacting with the data. And I have here underlined by the interventional cardiologist. So what we're trying to ask is a shift in how we interact with this information. We, particularly us in the procedural field, have maybe not in structural interventions, where I think this is done more commonly, but for coronary artery disease, we have not historically necessarily interacted directly with that information. We have looked at paper reports, at PDFs, and that say there's a severe lesion, consider an angiogram or whatnot, but we have not, again, directly interacted with that data. So the definition of CT-guided PCI is that the that proceduralist, that interventional cardiologist is going to actually look at that images either independently if you're comfortable and trained in understanding how to look at CT, and I'm sure we're going to discuss what some of the unmet needs and barriers are, or if you have to go and talk to your friendly cardiac imager or radiologist to help you look at that information. But again, you want to look at that information together. And again, for many of you that may be, participating in this webinar and listening to this, you may say, well, I do this all the time in structural interventions. And that has certainly been the case for other conditions in cardiovascular disease. I think transcatheter aortic valve replacement is probably the best example that now for many, many years, doing a CT for pre-procedural planning to understand the access size, the route for implanting that valve, the valve size, whatnot, has really been integrated as part of routine care for the management of severe aortic stenosis. This has not been the case for coronary artery disease, and specifically using CT. And this is where I think we can really piggyback on some of those concepts and really embrace the lessons of using a heart team and multidisciplinary collaboration from CT. Now, some of you may ask, may in all fairness, may say, well, is this, premature? Are we in the infancy of CT for coronary disease? Are we ready for prime time? And don't get me wrong. I think there's inevitably, yes, we want more data. There's need for more trials. But I think it's also important to recognize that there are a number of already published randomized controlled trials. I'm not talking about single center retrospective observational studies. We're talking about high level data that already indicates that if we use CT for pre-procedural planning of coronary interventions, it can help with outcomes and procedural planning in these patients. I'll start on the left. For patients that have the most difficult coronary lesions, those are chronic total occlusions. We already have a randomized controlled trial, the CT-CTO trial, showing that if you use CT for PCI guidance, that leads to improved procedural success and fewer complications. Now, for coronary artery bypass graft surgery, a population that we see not infrequently in the cardiac catheterization laboratory, we have not one, but two randomized trials showing that there are reductions in procedural time and contrast-induced nephropathy. And there's a recent randomized pilot trial looking at osteo lesions that also shows that this helps with stent positioning, reductions in procedural time, contrast, and radiation dose. So just to allude to the point that there is an increasing amount of high-level data really validating the fact that CT can really help with procedural planning and outcomes. The pivotal trial in this field has just recently completed enrollment. I think this is right now the major all-comers trial in this field. It's called the P4 trial. Many centers in Europe, we were part of the leading site in the US enrolling for this particular trial. It's a non-inferiority trial that randomized patients to CT-guided PCI in comparison to IVUS-guided PCI for the primary endpoint of MACE, cardiac death, target vessel myocardial infarction, or ischemia-driven target revascularization at 1 year. So I think, this would be a very important, trial to await the results, hopefully next year, that will further, provide some clarity on what is the rule for PCI guidance, particularly from a clinical outcomes perspective. And we'll talk about some of the components, but be aware, just to highlight, that there's a number of high-level data efforts and trials ongoing in this field. Now, in our practice, we have embraced this. Yes, we recognize that this efforts from a clinical research perspective are ongoing, but again, there's a number of data that support this initiative as of now, and we've started doing CT-guided PCI on a very systematic fashion, I would say, as early as 2023. Our journey, and again, this journey is going to be different for everybody. Our journey initially started with physiology, with CT-based physiology, in which pretty much we were able to transition from using, again, I think this concept of using a tool that has been historically just for diagnosis, but now for PCI planning. This applied to FFRCT as well, where we were using initially FFRCT for about a decade just for diagnosis of functional coronary artery disease, and we shifted to using these 3D models now for pretty much virtual PCI planning, understanding optimal angles and stent length. This is how our journey started on the clinical use of CT-guided PCI here in Minneapolis. And if you think about this little by little, all the elements came together. And this is what I like to call the one-page pre-procedural plan of how now you can put an entire package to really prepare before you enter the cardiac catheterization laboratory. And I often like to say that we need to be humble about our field. If you think about PCI, coronary interventions, the stenting, there have been a quote-unquote negative trial like COURAGE or ischemia that have indicated, that as compared to medical therapy, PCI did not have as favorable outcomes as expected. But you may ask yourself, well, are we using enough intravascular imaging to support the guidance of these procedures? Are we using enough physiology? Are we really planning those procedures to the best of our abilities? And this is where CT has the promise that all this information, whether that's anatomical information or physiology information, can be provided to you, prior to the procedure for you to plan accordingly. So again, this is from our clinical cases, from our experience, and how we've integrated this in a very digestible format, the one-page pre-procedural plan. And we'll talk about these elements, but you have an MIP, maximal intensity projection, that gives you an understanding of anatomy, of vessel anatomy, course, and whether there's calcium. So here, easily, you don't have to be a level 3 expert reader to understand that this is, LAD diagonal with some calcium in the proximal LAD. So as a proceduralist, you already have your mind oriented in a particular way. You understand the origin of the coronary arteries. Here, for example, the right is a little bit anterior, so you may use a special type of catheter, potentially an AL1 to engage this. You know what the landing zones are here for where's the healthy landing zones for your stents. So here we're thinking 22 millimeters. You can understand vessel size. And now there's a number of emerging technologies that allow you to better and very easily understand things like calcium and physiology. On the left, looking at calcium, as you can see, a concentric severe coronary calcification in the middle AD. And you can then look at physiology as we've talked before. So now, rather than the status quo in one way, that we go into these procedures and sometimes we don't necessarily know what we're getting into until we really do that invasive coronary angiogram. With CT, as you can see, you can have a checklist and say, hey, this is my CT, and I know it's a calcific LAD diagonal. Therefore, I know this, since this is a bifurcation and it's calcified, I must plan this at my primary hospital with all the necessary equipment. I need 2 wires. I need a 22 millimeter stent. This is the optimal angulation. And again, it really mirrors to some degree what we've been doing in TAVR, but now for coronary interventions. This is a group that came together in Minneapolis in October 2024 to really try to, consolidate many of these educational concepts. And for listeners and viewers of this is the nomenclature. If you are a cardiac imager, radiologist, this is what you know and the language that you use every day. But this is the language that we would invite you to also pass along to our procedures, interventional cardiologists, your trainees and whatnot, because we need to communicate, right? Like, not everybody knows what an MIP is, maximal intensity projection. What are the elements? So on the left are elements that can be acquired with any post-processing system, like MIP, axial images, multi-planar reformations, and short axis cross-section. And on the right are other complementary pieces that can help with a PCI planning, such as physiology, virtual PCI, myocardial mass, and live guidance from CRM and CT code registration. Now, why has our practice embraced this? Our practice has embraced this because this is a great tool for triage. Again, if you interact with the data, you can see that the case on the left is a focal, non-calcified mid-RCA lesion. This is not complex. This can be done at any accessible PCI center by any available interventional cardiologist at any time using standard PCI equipment. Whereas on the right, you can see here is a heavily calcified circumflex coming very close to the left main, diffusely diseased. This is diffuse complex calcific coronary artery disease. This is something that conversely to this case on the left, you want to plan at your complex PCI center by one of your complex operators. with enough sufficient time and preparation, and you can anticipate what equipment you might have to deal with this degree of calcification. So how we've sort of incorporated this is that this really helps with procedural triage as to where you're going to do it, who's the right operator, when should it be done, what equipment do you anticipate to do, and this really promotes planning. Now, this is the MIP projection. This is something that, for those of you that are cardiac imagers, radiologists, many of you are potentially not using this as part of your standard workflow for several reasons that you very well know. But for the procedurals, for the interventional cardiologists, this is a very easy image to understand. On the case on the left, you see no calcium, you see a focal mid RCA. Everybody will understand coronary anatomy and understand that this is a relatively straightforward lesion to treat percutaneously. Whereas on the right, without advanced CT training, etc., you can in one image really understand the story that this is a calcified lesion, that you may need more procedural support and equipment to deal with this calcium modification. So this is one image that we like, not necessarily for diagnosis of the specific severity of the lesions, but just because in one image, you can quickly triage case complexity, understand coarse anatomy, and optimal fluoroscopic angles. We've talked about axial images, which helps you with the origins of the coronaries, which they're right if it's not coming at 11 o'clock. If it's coming more anterior, like at noon, you need like an AL1. You can also measure the cross-section across the aorta to inform your guides. In this particular example, it's a dilated, aorta 48 millimeters. So, you may need a larger guide catheter than you would usually use. And this all helps, as in this example, because in this right, you see the RCA coming very anterior. So therefore, at the upfront, you need an AL1 catheter. This saves you radiation. This saves you contrast. And it really helps with procedural efficiency. And these are some of the concepts that right now are being evaluated and tested in ongoing prospective studies and trials. Now, for many of us already know from intravascular imaging, things like IVUS or OCT, what are the elements that we care about for PCI planning? And it's not too complex. We care about the morphology of the lesion. Is it calcified or not? How long the disease is? What are our landing zones? What is the size of the stent that we want? And is there an optimal projection that we want to use for this? And this can all be acquired from CT, as illustrated here, in which you can understand in an MIP easily the anatomy, but on the right, on a multiplanar reformation and cross-sections, you can understand where those landing zones are, what's the length of the disease. You can anticipate what balloon and stent size you may need. An incredibly important teaching point would be on this: make sure that your CTs are well nitrated for image acquisition, because if you are going to rely or trust some of these CT assessments for a stent sizing, not length, but the size of the stent, then you're going to make sure that this is well nitrated vessel acquisitions, ideally 800 micrograms of nitro. Again, this is the multiplanar reformations, reconstructions that all of you will use all the time to look at disease. Many people will look at double obliques on a routine basis for diagnostic purposes, an automated multiplanar reconstruction now for PCI planning, because the diagnosis has already been made. It's a very facile format to really interact with the information, particularly for those that are not, trained in cardiac imaging. Now, shifting to calcium. Calcium is an incredibly important topic in CT-guided PCI. This is something that is a very interesting story, because as many of you know, I'm sure many of you have heard this, calcium used to be perceived to be a weakness of CT, that we cannot say anything about diagnosis or planning because there's blooming artifacts, which is true, but morphology, it's increasingly recognized that you cannot fake morphology. Here you see some examples that you see concentric calcification or very severe, arcs of calcium. If you have a significant arc of calcium, that's something that will make you think from a procedural perspective, already put you in a mindset of thinking about support and thinking about potential advanced calcium modification strategies, whether that's atherectomy, intravascular lithotripsy, or specialty balloons. So very important and interesting historical journey of how calcium has been something that we wanted to shy away from imaging acquisition, to now that's something we actually want to embrace and understand, because it helps us with our procedural planning. There's now novel technologies that are helping better interact with this with calcium, that particularly for people that really want to have easy data set to interact with the information. This is quantitative CT interactive plaque that just by scrolling through a automatically selected data set will give you an understanding of plaque and calcium to really understand that anatomy. Now, as part of the randomized trial that I alluded before, these investigational applications looking at 3D models of plaque and calcium were elaborated. And this is important, I think, because it illustrates two emergent concepts that CT provides and brings to the table, that intravascular imaging does not give you as a clear format. One is calcium distribution. You can see in this 3D model, so you can nicely understand where is that calcium distributed across the vessel. That's A. And B, calcium density. Understand that not all calcium is created equal, and that there's some calcium that, let's say, are going to have, some are going to be easier to break with a standard balloon. There's others that are going to be very hard, and you're going to need things like lithotripsy or atherectomy to really break that calcium. So this is an evolving story, but we're learning with CT how we can really interact with this information in a different way. Now, shifting to physiology, it's important because, like as I alluded earlier on, this is something that has transitioned from a diagnostic application to a therapeutic interventional application. You can see these two cases, they have the same FFRCT dystally of 0.63, 0.64, but they're completely different disease phenotypes. The disease here has proximal LAD with a huge significant step down from 0.97 to 0.68. This is a focal lesion that will likely benefit from PCI, whereas the case on the right has a tapered gradual decay on FFRCT. This is more diffuse disease. This is unlikely to benefit from PCI. This is something that will more likely benefit from medical therapy. But what has changed really how we think about it is that now there are dedicated tools for us to interact with CT for PCI planning. This is a virtual PCI planner, and now you can use these 3D models to implant stents virtually and understand what is the predicted post-PCI FFRCT. In this example, you can see that by placing a middle AV stent, it would be insufficient to resolve and improve the distal FFR, and that covering the proximal disease, you would really get a more favorable result with FFRCTs at a more acceptable range if you cover the entire disease. So you can see now, if you can, certainly you can make these decisions with invasive equipment in the cath lab, but if you can get this information before you enter the cath lab, it can be very helpful. We've talked about some of those specific lesion subsets. CTO is an incredibly important one. Here is the trial, the CT-CTO trial that I mentioned before, that if you use CT, you can really get a lot of information to help with your understanding of anatomy, complexity, CTO length, cap, many components that we care for CTO PCI planning. And if we integrate this into our workflow, we can, the trial shows that there's higher procedural success with fewer immediate per-procedure complications. This is the traditional approach of looking at this, in which we look at MIPs, slice thickening, multiplanar reformations, double oblique views, to really look at the CTOs. But the reason I want to highlight is because we're entering this new phase of, we have entered this new phase of AI and different ways to interact with the data. This is now, the application of AI QCT that now automatically here from the O to O tells you the occlusion length automatically detected, displayed. You can display this in a 3D model, and you can correlate here with invasive angiogram. This is something that, we have integrated into our clinical practice. We're still learning how to use this, but just understand that again, many of these lesion subsets, there's different applications. It goes from physiology, it can go from even occlusion characterization, as in this example. Now, this is now the other thing that I want to highlight, which is the issue of intraprocedural guidance. This is intraprocedural guidance, in which you can see here that now gives you not only the whole pre-procedure planning that we just discussed at length, but now you can use CT for live guidance during the procedure. So if you do that CT acquisition, now you can integrate with your fluoroscopic C-arm, that 3D model, and as you rotate your arm, or your C-arm, you can see how that model moves. And why is this potentially beneficial? This is potentially beneficial because therefore you can reduce foreshortening, get the best angle, reduce use of radiation, reduce use of contrast, understand better landing zones. So again, an evolving issue that it's happening right now in this field of CT-guided PCI. there are different models that have been tested over the years. There are some that are direct overlay. There are some like are right next to each other. On the left, I'm showing the one that we evaluated as part of the pivotal CT-guided PCI trial that I alluded to before. But now to conclude and start wrapping up, I would like to say that it's very clear that we're in the early adopter phase. We're clearly need more clinical trials, implementation science, cost effectiveness studies, but there's many opportunities for us to learn how to use CT. This is where this initiative of the partnership between SCCT and SCAI was incredibly timely to identify the unmet needs, barriers, and opportunities. These are all described in the document, but go from issues that relate to hardware and software to the need for more evidence, and some issues that I want to discuss further, such as education, collaboration, and reimbursement. Evidence is incredibly important. As I alluded to, I think right now the pivotal P4 trial will provide the level of data that we need to better clarify how this field is going to evolve. But education and collaboration is incredibly important, such as this webinar that we're doing here today, to really educate our peers about what the emerging opportunities are. I think something that has been great, and I want to highlight that partnership and collaboration, is that our interventional cardiologists and proceduralists may not know many of these opportunities, and we need to partner with our imagers and vice versa. The imagers may not know how the proceduralists may interact with this information for PCI planning. So there's a lot of initiatives as shown on the right to have this pretty, multidisciplinary cross-sectional partnership for us to understand how to embrace this. So I'll just conclude by saying that we're really shifting from the past of us just looking at just one report, and that I think there's this very exciting time for coronary interventions and coronary PCI planning and diagnosis, that by interacting with the data, we can do, hopefully a better job for our patients. So thank you so much.
Thank you, Dr. Sandoval. That was a lot of great information. I know CT-guided PCI is something you've considered for a long time, but maybe the hardware and the software weren't quite really where we needed them to be. Would you say that we're now in a place to make CT-guided PCI happen routinely?
Absolutely. As I mentioned, I think, of course, there's this ongoing trials that we're going to, will hopefully confirm some of the perceptions that we feel have added value to clinical care. But historically, we've been doing CT for so many years, right? And what made it accessible now is that the image quality, and I know this is going to be discussed in the subsequent presentation, but image quality of contemporary scanners and the ability to interact with this information in a facile manner is now at a stage that I think makes all this information digestible to pretty much the broader community, and I think that's a key component. So I think we're also entering into this new phase of AI and better ways to display some of this information in a very easy methods that I think is going to democratize our field and really allow everybody to look at these images to help with diagnosis or procedure planning.
Yeah. What are you hearing amongst your peers? Has there been some resistance among them for starting CTI, PCI to be a routine, or is there anything preventing the change from them?
Yeah, no, I think this is still in the early phase, and I think there's a number of barriers. One barrier, and again, I applaud, this effort to have this sort of education, including SCCT, is that we need increasing partnership with our with images and radiologists. I can tell you that right now a major barrier is, for example, that many proceduralists, for example, specifically, may not have access to the softwares to interact with this information. So, you want to make sure that you have access to your post-processing software that you're using at your hospital. You want to, sometimes this is restricted by number of licenses or whatnot. So access, I guess, is what I'm trying to get at. Access is a major barrier, and this will only be resolved by us understanding that there's another set of users that want to interact with this information. But in order for this to occur, the imagers need to be aware that there's that need, and vice versa.
Yeah, thank you. Well, before we move on to our next speaker, I just wanted to ask you about the multidisciplinary paper that you mentioned. It came from both the Interventional and Imaging Societies, SCAI and SCCT. in a nutshell, what do you consider to be the main message and takeaways from that initiative?
There's several things that we've discussed already, which I think relate to education of this emerging initiative, and just be clear about what is CT-guided PCI, which means interacting with the data. I think it's probably the one message that I would highlight. But I think the other message are that there's a number of unmet needs and still a need for a lot of data and trials and evidence. And I think that the only way to move forward here is going to be not only that new scientific evidence, but pretty much education and collaboration. So I think what has been, I think, very exciting, particularly in coronary artery disease, that I think for many years that there have not been as many, developments, let's say, as a structural disease. For coronary disease specifically, I think something that has been very exciting is that it has brought people in the room together to discuss and learn from each other, and hopefully we'll find new methods to challenge the field and do better for our patients.
Thank you again for joining us today. This is exciting. We look forward to the future of where this is headed. And for anyone that's interested in reading the paper, we're going to link it below. So we've talked about the amazing direction that AI post-processing can take us, but at the root of it, if we don't have great clinical images, as Dr. Sandoval mentioned, the AI really isn't going to help us. So at this point, we're going to switch directions and invite Rolf to talk about CT image quality and the benefits obtained with spectral CT imaging. Thank you again, Dr. Sandoval.
Thank you, Chris, for your kind introduction. First of all, I'd like to thank Dr. Sandoval for his sharing his great insights on CT-guided PCI, which is a topic which is very close to my heart, and I also foresee a great future in that. But as Chris mentioned, let's go one step back and let's go in the area of the coronary diagnosis. So is spectral CT, and how spectral CT will add new dimensions to the cardiovascular domain. It took a while, over 20 years, but for now, the door to non-invasive coronary CT is wide open, especially for the low to intermediate risk patients. And as you can see here in this nice video, this is coming from a hospital in Chibanishi, outside of Tokyo, and they are capable of doing 50 cardiacs in one single day. So it took 20 years. Well, the hardware is there. All the vendors provided cardiac images with hardware to provide cardiac imaging in a robust fashion in quite a significant variation of heart rates, etc. So all vendors are capable of doing that. Then, so we have the hardware. Then we have the image reconstruction chain. And we all know over the 20 years, there was significant progress. And this is an example of the Philips history, more or less. So let's say 15 years ago, we had to reconstruct coronary CT with filter back projection, what you see here on the left. A very noisy imaging, high dose. And then, yeah, you didn't need, you could deal with a lot of noise to identify this subtotal lesion in prox LAD. But then if you go to your short axis images, you lose completely, right? You cannot distinguish where the outward remodeling stops and the pericoronary fat starts, right? So not as good. Then we changed to a hybrid iterative reconstruction, of course, with lower dose and less noise. We improved image quality, and yes, you could also see that in the cross-sectional, in the IVUS cut here on the image that I'm pointing at now. And then we started to go into the fully iterative reconstruction. In Philips, it's labeled IMR, and you see you get a virtual noise-free image of the coronaries, and you get exquisite image quality showing this subtotal lesion, which I could see on the left. Yes, I know, but this is at significant lower dose. And look at the image here on the bottom. This is state of art. This is what you want to have, right? You want to have great detail. You want to see the outward remodeled, non-calcified plaque, so you can do all your measurements, which might be relevant for CT-guided PCI, as mentioned before by Dr. Sandoval. So the hardware is there, the software is there, but last but not least, cardiac images, you are perfect, right, in doing research. There's no other community like cardiologists who are they play an exquisite role in setting up trials and producing data. So there are several landmark studies like the Scott Hart, and all these papers are now recommending a more prominent role for coronary CTA in non-invasive coronary artery diagnosis, right? So hardware is there, the robustness, the image quality is there, the proof is there, the ESC, the ACC, the SCCT. Now coronary CT is established as a primary method for identifying coronary artery disease in this patient population. But then spectral coronary CT is already that good. But why? Why then should we add spectral to the equation? What is the value? So let's have a deep dive on that. So the most important thing when you do coronary CT is and your scanner needs to do is freezing coronary motion. And again, all vendors are capable of doing that. One vendor will say they are better than the other. Trust me, all vendors are capable of doing this. But then, even when you have a 17-segment coronary tree without motion, you are not out of the woods. And as you read coronaries, you will quickly understand what I'm alluding to. You still have challenges that you're facing. You're dealing with blooming of high-density objects like in calcified plaques and stents, right? And that might lead to false positives. We are dealing with a typical CT artifact labeled beam hardening and metal artifacts, and they are especially hindering when, for example, now when we read coronaries, but also when we look at the myocardium to assess a potential first-pass perfusion deficit. We have challenges, especially of sometimes in patients with poor kidney function with respect to the iodine load. Patients with poor kidney function or patients who do not tolerate a lot of additional iodine or volume, for example, pre-TAVI patients, pre-TAVI assessment. Then we don't always have the optimal enhancement of our coronaries, and cardiac imagers get very nervous when, for example, the PDA is not very well enhanced. And this suboptimal enhancement can be due to timing issues or a technical failure like pressure limiting of your power injector or whatsoever. And then we are dealing with the characterization of non-calcified plaque, and this is the topic of research as we speak. And it's not that easy to identify high-risk plaque features like fatty deposits within a plaque. And we know by research that there is a significant overlap in Hounsfield units from fat and fibrotic tissue. So Hounsfield unit is not robust enough. Then sometimes we see a filling defect in the left atrial appendage or in the LV or the RV. And then it's a challenge. Are we looking at a clot or are we looking at slow flow, stasis, or perhaps a tumor? And you know, when you read coronaries, when you do a cardiac CT, you should not only look at coronaries, but you should comment on everything else. You need to look at the size of the chambers. You need to look at the valves. Are they calcified, yes or no? You also need to look at the myocardium. Is it thin? Is it thick? Is it perfused? Yeah. Is it well perfused, homogeneously perfused, etc. And that is all challenging on conventional CT. So all the things that I listed here, you do not solve these issues with by definition a 16 centimeter or a fancy scan mode, whatever. This is all linked. All the things that I listed, that I discussed here, are linked to the single energy nature of. They're all linked to the single energy nature of conventional CT. So what is the solution? Well, the solution is spectral detector CT. Every photon counts, so instead of looking only at conventional CT, single energy, we maximize the value of each and every photon by providing novel maps coming from two energy levels, a high energy level and a low energy level. And these, on our scanner platform, these two different energy data sets are extracted from our detector-based dual energy scanner. Detector-based dual energy comes without a single penalty. So we do not impact temporal resolution, radiation dose. We do not exclude the high BMI patients, and also the resolution remains intact. So this is the only scanner, this is unique to Philips, where which provides you the spectral data on top of conventional without a single penalty. So that's all great. and I'm not going into the details of how this detector works, etc. No, because clinical speaks, right? Clinical tells the story. So let's go and let's try to go through all the things that I mentioned as being challenges that you are facing today. So in this case, we're looking at blooming, right? And here we see calcified plaque in PROX LAD here. And then this is one of the blooming of calcified plaques, is one of the main reasons why people are sent to an invasive cath for no reason, because the true vessel lumen is underestimated. Now, and this has to do with the learning curve of the cardiac imager, etc. But this is one of the main reasons of false positives. Now, on conventional, it looks like this. And you might think, oh, this might be 50, 60%. But then when you start to look at spectral data, so this image on the right is a virtual monoenergetic image, an image as if we scanned the patient with one single energy at 150 keV level, for example, we see a significant reduction of the blooming of the calcified plaque. So now on the image on the right, I know now with confidence that I'm only looking at a 30% stenosis. This patient doesn't need to go to the cath. And for example, on the image on the left, on conventional only, the patient might have been sent to cath. Now, by adding spectral, I know this patient doesn't need to go to the cath. Another example, short axis, PROX LAD, really nice image quality. And then here again, in the IVUS cut, you think this is 50 to 70%. Should I go to cath? Well, depending on the location, PROX LAD, yeah, we might do it, we might not do it. I don't know. Well, there are too many queries in the reports from cardiac images, and a referring physician doesn't like queries like maybe, yeah, could be, I don't know, probably. They don't like that. They want to hear yes or no. Well, again, in this example, when we are adding an additional map in virtual monoenergetic 150 keV, you see there is a significant reduction of the calcium blooming. So now, again, I feel very confident that this is only a mild stenosis. So in this way, spectral helps to improve the confidence for a cardiac imager to call a lesion a significant lesion, yes or no, and to minimize the false positives and to significantly reduce sending patients to a cath lab which should not go there. Artifacts, I told you, beam hardening, metal artifacts are another issue. This patient had atypical chest pain, coronary CTA was ordered, patient had a pacemaker, and then a wire is running through the heart, and when it's moving, you get significant streak artifacts. And you see here on the left, there is a significant decrease in image quality of this PROX mid RCA. That's not what we like. That's not what we want. We might potentially miss non-calcified plaque. So again, iodine or water. Iodine or water is a different spectral result. You can see them all listed here on the left of the screen. Conventional CT is what you have today. Virtual mono E is what I showed you to reduce calcium blooming. Now I'm using an iodine or water map. And this map is available at your fingers with a click on the PACS. So now you see these beam hardening and streak artifacts are significantly reduced, and now I can easily access this proximal and mid RCA without any issue. Plaque assessment, very, very hot topic. Now here we see again, nice image quality. We see a significant plaque burden in PROX LAD, and plaque, looking at grayscale, and you might drop a Hounsfield unit, but that's dangerous. We all know that. This is a dense zone. This is a little bit hypodense. This is a spotty calcification, but you want to know, is there a fatty deposit? Because if there is a fatty deposit, it's by definition a high-risk plaque feature, and it might even be a napkin ring sign. So, you want to be able to detect that in a reliable fashion. But with current conventional CT, you cannot. Now, what is spectral capable of? Well, we can extract the so-called attenuation curves. So what do? We drop several ROIs in different sections of the plaque, of this artery. So the red ROI is positioned in the vessel lumen, the green one is in the spotty calcification, the blue one is in the supposed, it is hypodense, so we suppose this is fat, and the white one is in also non-calcified plaque, but it shows a little bit higher density. Now, is there now a fatty deposit in the plaque. Now, if we look at the attenuation curves, which you see here, on the x-axis we see energy level, on the y-axis we see CT number, you see the fatty rich plaque, which it's where the white ROI is positioned. You see, this is more or less a horizontal line over the entire energy axis, whilst when we look at the curve for extracted from the blue ROI, you see that the moment we go to low mono E is everything below 70 keV, you see there is a significant decrease in a decline in CT number. The blue line is the signature of fat. Fat is the only tissue in your body which shows this behavior. So now, not based on Hounsfield unit, but based on the spectral attenuation curve, I know with 100% confidence that there is a fatty deposit within this plaque. So again, it brings confidence to a level that a referring physician expects from cardiac images. So that's where spectral comes in to help. Stent imaging. Patients come in with stents and with recurrent chest pain. Well, this is a patient with multiple stents at RCA. This is not the Sharper's kernel, and in all honesty, I don't really care. Do you really want to see the stent stretch? I don't think so. You want to see if there is something inside. Well, again, here in this curved MPR, is there something here? I see there some haziness. Is that could be some motion, could be some beam hardening, metal artifact? I don't know. Again, I don't know. Referring physicians don't like I don't know. So on conventional, you are not conclusive in what's happening within the stent. Now, what's the solution? You just click and you change this image from conventional into iodine or water. See what's happening? Significant reduction of the stent stretch. I don't want to see that. And now it reveals a significant subtotal in-stent ray stenosis. So now you know that this patient definitely needs to go to the interventional lab. Look at the second stent, the more distal stent. You know, it really looks lovely, right? And there is no stenosis visible. Patient went to the cath for a good reason. So we increased the diagnostic certainty. The patient went to the cath, and look at that. Excellent correlation with this significant in-stent ray stenosis, and the distal stent is beautiful. This is what spectral will do. Another example, a Sharper kernel used. This is quite a large stent in LAD. And then again, there is this subtle lesion based on conventional. What am I looking at here? Is this intimal hyperplasia? Again, I am not so sure. Well, you know by now the answer is spectral. So you just do an additional click, no additional scan. This is just an additional click. And we extract an iodine or water image. And with iodine or water, I reach the confidence level that I need. Here, I'm talking about in-stent ray stenosis, period. So that is what spectral will do. Now, this patient had acute chest pain, coronary CTA, and then when you see here at segment 3, we are missing. So this is a subtotal, most likely a subtotal occlusion of the RCA segment 3. Now, if this is true and there is acute chest pain, are we looking here at a first pass perfusion deficit? You see this slightly hypodense zone? Well, I don't know, Rolf, because this is the area in the myocardium which is highly susceptible to the so-called beam hardening artifact, because this tissue is squeezed in between high density iodine in the aorta and high density iodine within the ventricle. So that is by definition beam hardening. So now I don't know. What's the solution? Spectral is a solution. With spectral CT, well, spectral CT, detector-based spectral CT is the only way how you can solve the beam hardening artifacts. So now, are you ready? Let's have a look at the spectral data. Look at the left lower image. This is a virtual monoenergetic image, 40 kiloelectron volt, close to the kH of iodine, so you get maximum iodine boosting. This is noise-free and there is no beam hardening. Now, even a junior cardiac imager will quickly identify that there is a significant first-pass perfusion present in this section of the myocardium. Look at your Z-effective. Z-effective is an additional spectral map. It comes in color and it tells you something about the atomic numbers of the elements within a voxel. Now, when there is iodine on board, Z-effective It's more or less like a color-coded iodine map. So I can clearly see here the orange area which shows low Z, and low Z means no iodine, because iodine blue in the LV, and there is a good amount of iodine within the well-perfused left ventricle here, the myocardium. We can also extract iodine information, and iodine maps, what you see here on the right upper image, iodine images now not only qualitatively show if there is iodine penetrating, but you can also quantify iodine. So if I drop an ROI here in the free wall, I measure 2.4 milligram per milliliter iodine. Okay, that's good. But then if I drop an ROI in this section of the myocardium, I only measure 0.5 milligram per milliliter. So now you can easily extract the ratio between healthy and unhealthy myocardial tissue. Qualitative and quantitative iodine assessment. Of course, by using iodine maps, we can provide you with the with these quantification tools on the total amount of affected myocardial tissue, which again, if it exceeds a certain percentage of volume, is a trigger for the interventionalist to go in and to do something. Another case, a lovely one. You see this on the left. There is some mild disease in left main. Then we see a tandem lesion in LAD. There is a subtotal lesion. At least this is how it looks like on your D1. Okay, significant disease. Look at the volume render. We never make a diagnosis on this, but we see this kind of shady area within the anterior wall, right? So is that something like a perfusion deficit? Well, I don't know. It might fit. At rest, significant lesion, you might show perfusion deficit, first pass. Well, let's have a look. See that? On the left upper, this is the conventional CT, what you have today. And then it is a challenge to identify if there is a perfusion deficit and the extent of the perfusion deficit. Well, if you start adding spectral data, which I show you here on the left lower, 40 keV, there is absolutely no doubt. You see that significant first pass perfusion deficit. You can also see that the entire papillary muscle is involved in the defect. Your Z effective shows the defect, and your iodine map shows the same. Really exciting case, this one. Atypical chest pain, CTA is ordered. We see non-calcified plaque in RCA, we see calcified plaques in LAD and in CIRC, etc. But we also see here on the left lower part, you see, I'm missing here my OM. So there is an OM occlusion. We're looking in short axis. Do we see a first pass perfusion deficit? Well, might not. There are some tricks to improve, but it's quite challenging, especially when you don't have a lot of experience under your belt. Again, adding spectral, it turns into Kinderspiel, right? This is very easy to identify with great confidence there is a significant perfusion deficit. So what are your peers doing who are using Spectral CT in their daily routine? They're adding late iodine enhancement to these kinds of studies when the CT is scanning ED patients. So this patient was scanned, first pass, and we waited 7 minutes. And at 7 minutes, we did a so-called late iodine enhancement scan. This is what you get. On the left part, this is oblique axial. We see here a transmural first pass perfusion deficit in the OM territory. We waited 7 minutes. Look at the image quality. This is the quality of late iodine enhancement that you get with Spectral CT. It is unprecedented image quality. And look at that. You see what you look here. See this part, this gray zone, this is perfused, but this zone is not perfused. So that is additional intel. And then you can label that the periphery being penumbra, and the endocardial part is the core of the infarct. And this is also additional information which you can provide to the interventional cardiologist, and most likely after intervention, the patient will still suffer from some residual wall motion and a negative impact on LV ejection fraction. So all this information with great confidence, and that's what Spectral is bringing to the table. Now we're going to talk about something really exciting, also very exciting, is the so-called one-stop shop. And this is a long desired thing by cardiac imagers. Now, a patient comes in to the ED with slightly elevated troponins, no dynamic changes to the ECG. Coronary CT was ordered. Coronary CT was normal. Okay. Then there is this differential. What are we looking at? Minoca? Oh, myocarditis. Yeah, probably myocarditis. Let's go to MR. Ah, there's a contraindication to MR. What do? Well, you don't despair. You just keep the patient on the couch and you do a late iodine enhancement scan. And that's what they did. And you can see the images on the left upper. This is conventional. Already a pretty good image, but still could be better. Look at the left lower. This is the spectral data. And you see here, this is the signature of myocarditis in a late iodine CT, similar to MR, right? We see subepicardial spotty late iodine enhancement, and it's confirmed on your Z-effective map and your iodine density maps in color. So we're not fighting MR. These indications like this, myocarditis, etc., is MR territory. But we just want to show that your peers are using this technology in case there is a contraindication for MR, or when there is no cardiac MR package on your system, or when there is a waiting list of 3 months on your system. You don't have to despair. Spectral CT is capable of doing excellent late iodine enhancement studies. Like this, people now are experimenting, or not experimenting, they are doing studies. And this is now patients with hypertrophic cardiomyopathy. And this is a late iodine enhancement scan. On the left upper, you see you see the hypertrophic myopathy, but it's very challenging to see the scar imaging here, right? The late iodine enhancement. Now look at that when you go to spectral and you change to 40 keV. Low mono E. It's very easy to identify the area of scar. And when we have iodine information, because we have iodine information at 7 minutes, you know what we can do? We can easily extract extracellular volume. But that's something that I'm going to show in a different case. This patient had CTO. And then you want to do a viability study. Again, I'm not bashing MR. Contraindication to MR. You want to do viability. You go to CT. You do a late iodine enhancement scan. And here you go. Look at your low mono E. Look at your Z effective. Look at your iodine. So this is all scar. So CT has great potential to scan late iodine enhancement, like late gadolinium enhancement, in patients who have contraindications to MR. And as I mentioned before, when we do a late scan, we have iodine information, we can quickly extract extracellular volume. ECV with CT, no problem at all. I'm almost at the end. What CT is also capable of spectral CT, is significantly reduce the iodine amount that you need. And you don't have to. And you can stick to 60 or 50 cc's of contrast that you use, depending on the scanner configuration you have. But with spectral, you can really go low. And instead of always using 4 or 5 cc's per second, this is how we were trained to do CTAs. No, with spectral, especially when you rely on low mono E, you don't have to inject at 5 cc's per second, but you can easily go back to 2 mLs per second. And then you do your calculation, and then you see you only end up with 18 mLs. 18 mLs at 2. This is very nice for patients who have a very poor kidney function. And then you might think, well, I don't like the enhancement that much. Okay, this is conventional at 18 at 2. So you might call this a watercolor painting. Well, let's change the watercolor painting. Let's change that into an oil paint, simply by using low mono E. And now this image looks like as if you injected 60 at 6. So this is another great added value of spectral in patients who have poor GFR, where you can still do a CTA with very low flow rates. So to conclude, spectral CT, well, what is better than ask a peer? And this is Dr. Eliseo Vanyo from Madrid. And he says, now, I get a comprehensive cardiac assessment in in less than 15 minutes. I see a reduction of unnecessary cath labs by reducing the false positives. He sees an increased referral from cardiology to CT by 10%. So according to, and I'm quoting Dr. Eliseo Vaño from Madrid, it's a game changer and it's a one-stop solution for cardiology patients. So there is only good news. So remember the list where I started off with when I on one of my first slides. Well, all these challenges with Spectral are resolved, if not significantly mitigated, when you apply Spectral CT on top of your conventional CT images as you are working today. So low mono-E is there to boost iodine, to reduce iodine load, to better visualize myocardial defects. High mono-E is there to reduce the calcium blooming, to solve beam hardening and perfusion deficits. iodine maps allow to qualitative and quantitative identify and assess perfusion deficits. Iodine and water helps to reduce streak artifacts. It works really well. It works really well in stent visualization. We have great potential for spectral data with respect to plaque characterization. I've shown that. Clot versus slow flow. I didn't show you that, but that's easily done by iodine maps, and late iodine enhancement is made easy with Spectral, and that really enables CT becoming the one-stop shop. Think about myocarditis, think about amyloidosis, sarcoidosis. We are, in our vision, we see these indications, leave the MR and go to CT because they are so easy to do when you are using a Spectral CT scanner. Now, with that, I would like to end the presentation and thank Chris and SCCT for the opportunity to present this beautiful technology. Thank you very much again.
Thank you, Ralph. That was such great information. Looking ahead, where do you see Spectral CT having the biggest impact in cardiac imaging for screening, diagnosis, or guiding interventions?
Well, I think definitely on the diagnosis side, and I showed multiple examples, but by providing cardiac images with the confidence level that they need, that is key. As I mentioned frequently, there are too many queries in the reports. Maybe, possibly, could be, might be. Referring physicians don't want that. They are looking for definite answers. So by mitigating calcium blooming, which is main reasons for false positives, less patients will be referred to the invasive cath. By using iodine maps, we can look inside stents. Low mono-E improves detection of potential first-pass deficits. And when you add late iodine enhancement, you even have your one-stop shop at hand. So definite biggest impact on diagnosis. However, CT-guided PCI, well, with respect to CT-guided PCI, Spectral will help in unraveling plaque composition, and that might help the interventionist in planning, as explained by Dr. Sandoval, and with respect to device selection and stent dimensions. So that's my line of thinking. That's our vision in Philips.
So from your experience with customers, what are some of the barriers clinicians are facing adopting Spectral CT, and how are we at Philips working to overcome them?
Yeah, well, usually the first thing what happens is when spectral scanners end up on a department, there is this little bit of there is this fear and fear of the huge amount of additional data. Well, that's not the case, because you don't have to necessarily look at all the different maps in every single patient. Each map has value in a specific query, but that requires training. And cardiac imagers to date, they did not learn dual energy CT or spectral CT. It was not part of their curriculum. So training is one thing. So in Philips, we take that very seriously. Of course, there are application specialists. They hand over the system. But with Spectral, it's something else. So what did we do? We came up with the idea to with the Spectral adoption specialists. We take that very seriously. So after application specialists leave, adoption specialists come to your site and they focus on the imagers. They train imagers on how to use. When do I use low mono-E? When do I use high mono-E? What is the value of iodine or water? So it's all about training. And the second thing is how a lot of data is workflow. And workflow is key. Now, with the Philips solution, how we, with, for example, Spectral Magic Glass on PACS, bring these spectral maps at the fingertips of a cardiac imager on his or her PACS, that's unprecedented. Nobody can do that. And that results in Spectral CT, detector-based dual energy CT, is the only viable dual energy solution within the market to date.
Great. Thank you so much again for sharing today. Your insights combined with those of Dr. Sandoval's are great examples of the exciting opportunity in front of us. Together, you've given us a powerful look at both the promise of CT-guided PCI and the future of spectral CT in cardiac care. And thank you to everyone who joined us for this webcast. We hope today's discussion gave you a clear sense of how CT is shaping the future of cardiology from intervention to imaging. And if you'd like to explore more, you can access Philips' latest resources by scanning the QR codes on the screen. Thank you.